Hi, I'm Christopher Baker, Associate Professor of Pediatrics and the Medical Director of the Ventilator Care Program at Children's Hospital, Colorado. Today we'll be talking about when children and babies require chronic ventilation for chronic respiratory failure. The approach to chronic ventilation is different from acute ventilation in a number of important ways. Most importantly, the goals of care are different. When a child is acutely ill, our desire is to avoid lung injury with gentle ventilation settings and a goal of really weaning ventilation support as readily as possible. However, for children with chronic lung disease, when chronic ventilation is indicated, a goal shifts from avoiding lung injury to supporting breathing and having a child be comfortable. So we want a child to be stable, to be able to grow and develop, to be able to bond with parents, especially important for babies, to be able to work with developmental therapists, and importantly, to be able to go home. In these cases, we often are thinking about tracheostomy tube placement with the goal of a child being able to breathe comfortably and have help from a ventilator to learn to walk, talk, eat. In some cases, for older children, a tracheostomy and chronic ventilation can enable them to live much longer as well. For the younger children, we view ventilation as a bridge to a period of time when they will stabilize, hopefully no longer to need the ventilator, have their tracheostomies removed, and continue with life without the developmental delays they might have suffered from had they not had their breathing supported early in life. However, the process for chronic ventilation is involved. It takes a long time, and it's a very long road for families to go with. We've developed a chronic ventilation roadmap to explain this process to families and really to help them understand their role in the process, as well as what our interdisciplinary team will provide for them throughout what can end up being a very lengthy hospital stay. We focus on parent education, and we say that it's very important from the beginning of the process that parents are involved to understand the decisions that are made as well as the interventions that their children are receiving. So the families have a lot to learn, they have to practice, and we emphasize that education is not just a box that is checked when something is said to somebody, but they really have to demonstrate the skills and show this with repetition, since their child's life could depend on it. We feel like families must be able to change a tracheostomy tube if there's a problem. They must be able to replace it, to suction it if it becomes blocked with mucus. They must be able to reassemble the ventilator circuit and know how to adjust settings and adjust oxygen levels in the case of emergency. And most importantly, when to identify that the child is having trouble in order to intervene and to call for more help. Our interdisciplinary team for chronic ventilation consists not just of pulmonologists like myself, but of many different providers. We have the intensive care unit teams, which are primary, often for babies. This is the neonatal intensive care unit and neonatologists, or pediatric critical care or cardiac intensive care for older children. There, in addition to the medical providers, there are surgical specialists such as otolaryngologists who will actually perform the tracheostomy surgery, and our interdisciplinary team that consists of nurses and respiratory therapists who provide the majority of the education, as well as developmental therapists such as pediatric occupational therapists, physical therapists, speech therapists, and feeding therapists who really help the child adapt to having a tracheostomy tube and moving forward, hopefully accomplishing developmental milestones that enable them to thrive and have a better life. In addition to the tracheostomy surgery, many children end up requiring a gastrostomy tube as well. Although with a tracheostomy tube in place, children and babies can learn to eat or continue eating. The gastrostomy tube is often helpful to provide additional calories and to take the pressure off for babies from learning to fully feed and having to fully feed by mouth to be able to make progress with feeding at a developmentally appropriate pace while receiving their calories via the gastrostomy. The surgical procedures often take at least a week, sometimes longer, to recover from, and then the transition to the home ventilator can take much longer. Especially for young babies who are very small, they may need to gain weight before they can meet the minimum requirements for being on a home ventilator. Most of the manufacturers have a minimum weight of 5 kilograms, and often our babies are 2 to 3 kilograms when the tracheostomy is placed, so they need to remain in the ICU to grow. However, once they're on a home ventilator, they can leave intensive care and be transitioned to our pulmonary team, to our Pediatric Respiratory Care Unit. At this point of leaving the ICU, the focus of care shifts from life-saving critical illness interventions to preparing to go home. The process for going home is involved, and there are 3 main components to ensure that the child and family are ready to go home. This consists of caregiver or parent education, making sure they know the skills like I described previously. We also, in many cases, have families who need home nursing, and there's a nationwide shortage of home nursing currently, which makes this process take time. The national requirement is not that every family has to have home nursing, but we have national guidelines from the American Thoracic Society, which suggests that a child who requires a tracheostomy tube and ventilator at home should have an awake and alert, fully trained caregiver with them at all times. Since often parents have other children or have jobs, have to go to work, the home nurses are nearly always a critical component of making this possible. But we will also work to educate other family caregivers, really friends and relatives, anybody that is willing to commit to be educated. We will help them become a part of a child's medical team, with our goal being safety at home. In addition to educating caregivers and finding home nursing, arranging the proper durable medical equipment, or DME, is of course important for going home. We also want to make sure that the home environment is safe and that there is a medical home or follow-up plan for each child. And although we have a very detailed roadmap which outlines the steps that all the families will go through, each child is unique, and so a customized plan has to be put together for each child and family to address their specific needs, both from a medical perspective and from a social and environmental perspective, given that many of our families come from places far away from the Denver metro area. The process of going through this in order to get home, it has a number of challenges. This is an enormous stress for families. It's one of the hardest things they've ever gone through. It can be incredibly rewarding, of course, to have a child who otherwise would not have survived be able to go home and to ultimately have a longer and enjoyable life. However, the stress involved is real, and so we work to support our families both with social work as well as psychological assistance as needed. There's so much for the family to learn, as we talked about, but we really try to involve individual small pieces and work with repetition and adding to what they've already learned and having families demonstrate their skills. We've involved a care process involving high fidelity simulation as well. Many hospitals use simulation to teach students and other hospital staff. However, our program has been one of the first in the country to use high fidelity mannequins that blink, that breathe, that have a tracheostomy and ventilator to have parents practice taking care of the children during a medical emergency, should that happen at home, so that they can do the right things in order to save their child's life at home. Many parents will have to intervene in an emergency at home where they have to actually save their child's life by performing CPR, by changing the trach urgently, by calling 911 to get more help, and by doing everything it takes to keep the child stable until that additional help gets there. And our families do this, and I think our simulation program is one of the reasons they're successful in that. When the children are ready to go home, they often will, the parents will complete an independent stay to demonstrate that they are stable. They will arrange for a car ride in order to practice loading in and out of vehicles. They will do our CPR training and our simulation, like I mentioned. And really our goal is to make sure that all members of the medical team, as well as the parents themselves, feel like there's a safe plan in place for discharge. Of course, it's a very exciting time. Families are thrilled to go home. They're eager to go home. And it's also an anxiety-provoking time in that families are understandably stressed that they'll be assuming all of the care or moving home. In some cases, our patients come from out of town, and so once education is done, rather than go home, we will coordinate a back transfer to a patient's home hospital. Of course, insurance and the medical teams at both hospitals have to approve of this plan, and we work to coordinate that transfer when we feel like, along with the family, this is the best decision for the child. And then after going home, children will return to our Ventilator Care Program clinic, where they will see pulmonary, speech therapy, respiratory therapy, and other specialists as needed in order to continue care in the outpatient setting. The child's safety is a parent's top priority. It's our top priority too. Thank you for your time today. For more information, please visit our Ventilator Care Program website or give us a call.